should cancel this. I don't do DoorDash that much.
Hey, Justin.
Hello.
Okay, let me pull up that PowerPoint that you sent.
Yeah, we only got up to allergies. I don't know if you want to go through the whole thing or just.
Yeah, it looks like a pretty short PowerPoint. It doesn't look like it's very long.
Yeah, we're pretty much almost done with everything. It's just all we have left is allergies and then our final. That's it.
Okay. Um, okay, where did it go? Here we go. Okay, let me share my screen. Okay, can you see my screen?
Yes.
Let's see. Um, okay, so you got up to what part?
Yeah, just allergies. We didn't. Yeah, so we stopped. We're supposed to go over asthma and COPD next class. That's it.
Okay. Okay. So, let me see. Let me see what she has in here. Okay. So allergies. Okay. So, obviously, you know a basic understanding of what an allergy is, right? Usually an allergy, when we think of allergies, we normally think of like, say, seasonal allergies, right? Watery eyes, skin gets itchy, puffy eyes, right? Red eyes, kind of things like that. A lot of nasal drip, sneezing,
Yep.
okay? And for some people can, it can cause some difficulty breathing.
Yeah.
It can be a little restrictive.
Yeah.
But what an allergy is just basically a hypersensitivity, okay? And for us, that can be anything, okay? There's some people who have so many allergies that they have to get allergy shots. Otherwise, they would probably die from dust and just normal things that we don't really think about, right? So, and this is all because of our antibodies. So IgA, IgD, IgE, and IgM. Okay. IgE is for our antibody, or it releases our antihistamines. Okay. So mainly with allergies. Okay. And so, sometimes we can have an allergy with an unknown cause. Okay. And sometimes we'll have an allergy to something once and then we never have it again. It just kind of, depends. But it's just your body overreacting to something. Okay. Our respiratory system. Hold on one second. I got a message here. Let me just. Hold on, Justin. Let me do this real quick. Hold on.
Yeah, go for it.
Okay. Okay, so respiratory system. Obviously, you know, we have our upper respiratory and our lower respiratory. Okay. And when we have stuff like asthma, bronchitis, emphysema, right, infections, all this stuff can cause problems if there's an allergy that affects our respiratory system, right? So an allergy, if somebody is allergic to cats, okay, and they have asthma, the stress from the allergy, okay, is going to trigger an asthma attack. Now, if they say even if they weren't, let's say, allergic to the cat to the point to where it would cause respiratory problems, right? Even in somebody who didn't have asthma, the person with asthma is going to be more likely to experience an attack because of the stress that they're experiencing on the body. Okay, and it's the same thing with, you know, emphysema and things like that. Antihistamines, okay? So our antihistamine drugs, like when we think of like Allegra, Benadryl, I'm trying to think of, Claritin, right? They all contain something called antihistamine, because when histamine is released by the cells, okay, our basophils, that's when that's what starts a reaction. Okay, the watery eyes, the itchy skin, you know, that's when it causes the reaction. So histamine blockers or antihistamines, okay, they're either histamine H receptor antagonists or histamine 2 antagonists. Okay, so either first or second generation drugs, and this limits the vasodilation. Okay, so like when you have postnasal drip, right, we have excess mucus. It's because everything is opened up, right? So antihistamines is going to cause more constriction, okay, and it's going to help dry those secretions, whether that's in your nose, your throat, right? It's gonna dry that up. Same thing with like puffy eyes or watery eyes. Okay, antihistamines are gonna work on that as well. Scratchy throat, things like that. Uses: seasonal allergies, allergic rhinitis, non-allergic rhinitis, release symptoms and allergic disorder, adjunctive therapy for anaphylaxis, and sedation. So, like something like Benadryl. Okay, we know Benadryl it contains antihistamines that make you drowsy, right? So we'll give it to people that need to kind of calm down or sleep, you know. They give it for patients with like dementia or mental health, even if they're not actually having an allergy, but they use it for the sedation effect. Without causing like respiratory depression, right, and all the things that we have to worry about with other sedative medications. For anaphylaxis, okay, we give like epinephrine, right? And then we're going to start giving histamines. Normally we don't, in that kind of setting, we'll probably inject a histamine, right? If somebody's going to anaphylaxis, especially anaphylactic shock, they're going to be in the hospital, right? Regardless of where they were, if it happened at home, right? They're going to be transferred to the hospital for observation, and there they'll most likely receive it via IV or injection. If somebody has, like, say, a really bad, say, like bees, right, or something that can easily cause anaphylactic shock or any type of anaphylaxis, then we're going to give them an EpiPen. Okay. So histamine's job is to basically provide inflammation. Okay, that's basically what histamine does. It causes inflammation, you know, in our eyes or nose, right? Our skin, okay? And then that's why we have the antihistamine, right? For hives, edema, things like that. But we can also take antihistamines, right? If you look at like cold medication, antihistamines are in there as well. And that's because of everything we just mentioned. It does all that great stuff, but we give it with the cold medicine, like you'll have antihistamine in there, Tylenol, okay, a couple of other things to help with the symptoms of your cold. Now, granted, cold medication is not going to get rid of your cold, right? You kind of have to just tough it out, but it's going to help manage your symptoms. And antihistamines is a big one because that's what stops your runny nose, or sometimes a lot of people have sore throat because of just postnasal drip, not because there's actually they don't have strep or anything. It's just from postnasal drip. Side effects, okay. Not too common, but it can happen. Constipation, blurred vision, dried mouth, urinary retention, dried thickened secretions. Some people might have central nervous system overstimulation, and others can cause sedation. So remember when we talked about giving Benadryl for patients like dementia and stuff like that? Some patients, for most people, Benadryl makes you sleepy.
Of course.
But for some patients who have neurological problems, as far as like dementia, even some like schizophrenia patients, it actually does the opposite and it ramps them up.
Yeah.
And normally the patient's taking a Benadryl along with other medications to help them sleep, but it is a complete opposite effect. And those patients. And it seems to help. From my experience, it seems to happen more when we give it for like mental health and things like that, than just for your day-to-day patient. But it does. It causes a lot of overstimulation, and when we're trying to get a patient to just lay in bed and chill out, no. Then you're gonna have to put them on a 1-on-1. An antihistamine overdose can be fatal, okay, especially in children, because remember we talked about that depression going on, okay? Let's see. If we give antihistamines with like hypnotic sedatives, tranquilizers, depressants, and alcohol, right, you can increase the effect of an antihistamine. So if for somebody, if the antihistamine makes them drowsy, okay, and we're giving them a hypnotic or a sedative or something, then it's going to increase that effect, okay? They're going to work with each other and depress the central nervous system even more. Let's see, when antihistamines are used along with ototoxic drugs, so these are drugs that are toxic to our ear. Antihistamines may relieve some of the symptoms of, they're used along with ototoxic drugs. The antihistamines may relieve some of the symptoms of ototoxicity, such as dizziness. Medications also interfere. Anticholinergies drugs can affect, and they may decrease the effect of corticosteroids and hormones. But this is like antihistamines if we're taking like chronically, like all the time. So if you're taking a corticosteroid and you're popping a Benadryl one time or Claritin, because you're mowing the yard or something, it's not gonna hurt anything. Lifespan. So infants, young children, their dosage for antihistamines are a lot lower than ours, obviously, right? Because of the sedative effect it can have. Elderly, same thing. Okay, it can really affect them and make them more drowsy. And because elderly, most of them are already fall risks. If we're giving them a Benadryl or any type of antihistamine that's going to increase the drowsiness, then we want to make sure that someone we do patient teaching, right, and we let them know that, or we keep a close eye on them, okay, to prevent falls and fainting and things like that, okay? Because antihistamines, like for me personally, if I take 2 Benadryls, I become like high. I'm like loopy, and I can't think properly. And that can happen with our elderly. So we have to be very careful, especially if they've never taken a specific type of antihistamine and they don't know how they're going to react to it. Leukotriene inhibitors. Okay. This is your Singulair, your Accolade, Zyflo CR. Okay. So these reduce the symptoms of asthma. Okay. By blocking receptors for acute or chronic asthma. Okay. If they're unable to take glucose steroids. They're one of the newer drugs categories for asthma. They're taken, they should be taken on an empty stomach because food can mess with the absorption. Usually there's not too much of side effect or adverse reactions. Headache is the most common side effects. And people, couple people have infection, nausea, and diarrhea, but they interact with things like warfarin, erythromycin, okay, aspirin. So, our blood thinner medications, okay, because we're causing vasodilation. Okay, so if we're using it for asthma, we're trying to open up the airway, right? So if we're taking drugs like warfarin, right, aspirin, things like that, we're causing even more vasodilation, which could increase their bleeding risk. Okay, so that's why they interact with those medications. Let's see, prophylactic treatment. Nitrochromic sodium. So this acts on mast cells, okay, to prevent the release of histamine, okay, and to slow the reaction of anaphylaxis. So this is just a prophylactic treatment, okay, because we're trying to prevent something, right? So prophylaxis is all preventative medication. So this is for somebody who says, let's say that they just have a lot of asthma attacks, okay, and maybe we're not sure of the triggers, or even if we are sure of the triggers and we can't control them, then we're going to give this along with their inhaler or whatever they're taking, right, to help decrease those episodes, okay? And this takes time to kick in, okay? We have to make sure that they take their medication as directed, okay, in order for it to work. So it's kind of like when we do with antibiotics. You can't just, miss a dose because you feel like it. You have to, be consistent with it, okay? Long term, let's see. What's a possible effect from hyposensitization? So basically what this is saying is that after a certain period of time, after long-term use, you can basically become so used to the medication that it might stop working. So then we have to adjust the dose. So just like, most medications, if you're taking it for years and years and years, or months and months and months, right, you develop like a useful, you become used to it, and then it no longer works, and we just have to adjust the dose. Decongestants. Okay, so this is usually for allergies. Some people are just congested all the time. They have a lot of mucus buildup, even if it's not related to allergies. Okay. So some decongestants, okay, we cannot take. Like I'll put this for kids. There's some decongestants we can't give for kids past a certain period of time. Like we can only give it to them for a couple of weeks, and then we have to stop because some can actually mess with their growth plate and start stunting growth. I'm not entirely sure the science 1,000% behind that, but it does happen. I'm not entirely sure why.
Yeah.
Yeah, I mean, because my daughter was taking a decongestant, and the one she was on, the doctor was like, she can only take it for this day. You have to stop it on this day, and they said because it can stunt her growth. And I was like, oh, well, all right then. Didn't think
for adverse reactions.
Yeah, I'm like, you don't think something you're gonna squirt in your nose typically is gonna cause mess with your height, but okay. So this causes vasoconstriction again. Because if the vessels are dilated, and that's what's causing all that secretion. Okay. Let's see. They're not, because it's like for like peds, they're not available over the counter. Okay, because again, they have to be prescribed. And it depends on the kid's height, weight, right? All that. Peds medications, we have to be very careful with. Okay, especially with if there's side effects like the one I just mentioned. Okay, so we have to make sure that they're a right fit, because not all decongestants are fit for all children. Corticosteroids. I'm sure you know what corticosteroids are. This is kind of one of those big medications that gets kind of those multi-use medications, right? We use corticosteroids for many different things, right? Reducing inflammation, for boosting, antibiotic use, for, we give it to chemo patients, right? And we want to help bring some of their energy levels up, right? But, and then this can also be good for long-term control of asthma. But when we do steroids, okay, eventually what can happen is steroids can cause immunosuppression over time. So we have to be very careful on how we give it and when we give it, okay? So this is why corticosteroids can cause like oral thrush and things like that. Can cause osteoporosis in adults, okay? Can inhibit growth in children, okay? So if we're giving corticosteroids, we're monitoring the patient very closely. It can, if somebody has diabetes, we have to inform the patient, right, that any type of steroid can increase their sugar, okay? So they may have to adjust their insulin dose. So if they see, hyperglycemic, if they see some sugar spikes, most likely it's due to the corticosteroid, okay? It can help with appetite. This is why we give it to, say, like some of our chemo patients, right? To help with like their appetite, things like that. But it can cause fluid retention, weight gain. Okay, can alter people's mood because it's a steroid, right? So just like any hormone, right? It can mess with somebody's mood. It can cause hypertension and peptic ulcers. Inhaled corticosteroids don't interact with many drugs. Systemic corticosteroids have a lot of interactions, okay? So like oral medications we're talking about, or even injected. Asthma. Okay, so asthma can be genetic. A lot of kids have asthma, okay, or are born with asthma and then they grow out of it. Okay, some do, some don't, and some people even have asthma into adulthood, and then even as they get older, it gets better.
That's good.
With time. So, do you have asthma?
I used to when I was a kid. I grew out of it though.
Oh, okay. Yeah, most kids, we call it childhood asthma.
Yeah.
And so usually, we obviously, we monitor it, right? But for most kids, they grow out of it. My aunt had asthma really, really bad, even into adulthood. And then now she's in her 50s and she doesn't even carry an inhaler. But in her 20s, she couldn't go anywhere without her inhaler. She had multiple inhalers because every day she used it. multiple times a day. So, for whatever reason, she got better. So asthma, right, is inflammation and swelling and mucus production that leads to bronchial constriction. Okay, so this is constriction in the bronchioles. Okay. Either sometimes they can still breathe, but they have wheezing, right? They have some difficulty wheezing. Or sometimes it's complete blockage, right? Complete constriction. We have 4 classes. We have intermittent, mild persistent, moderate persistent, and severe persistent. Okay. We have to give, remember that preventative treatment, we talked about that prophylactic. Okay, especially for somebody who has like severe or moderate asthma. Excuse me. But we want to make sure that they're staying away from their triggers, right? So if it's an allergy or, sometimes cold air can trigger, cold air typically helps with asthma, whereas warm weather can trigger an asthma attack. If somebody's having an asthma attack, then, and say they don't have the inhaler, we'll say, like turn on the shower, the steam, right, will help. So that's kind of like a home remedy, okay, to kind of buy you some time until, paramedics get there. Let's see, okay, so COPD. COPD is something a little different, right? COPD has to do with alveoli, right? Destruction of alveoli and unable to perfuse, right? We're not able to get that gas exchange in those little grape-like sacs. But asthma and COPD are both obstructive airway diseases. Okay, so COPD is not, is chronic obstructive pulmonary disease. It's not the same thing as asthma. Okay, but they're both obstructive airway diseases. Okay. And because asthma can be reversible, you may grow out of it, right? We can do things to make it better. But COPD, we can't reverse that. We can't change. Once the destruction to the alveoli are done, it's done. We can't do anything further, right? We can prevent the problem from maybe getting worse as much as we can, right? But we ultimately can't reverse the damage. Where asthma, it has to do with the bronchioles, so we can do that prophylactic treatment, right? We can make sure our patient stays away from, those triggers. Bronchodilators. Okay, so there's multiple types of bronchodilators, and we have something called symptomatics. It's like that's a mouthful word right there. And then we have something called anticholinergics. Okay, and with those medications, we typically don't. Some of them we can give together, and some of them we can't. Okay, because combined, sometimes they have a reverse effect. Okay, so there are the simple pathomedics. Okay, so it just relaxes that bronchi, right? So causes vasoconstriction of the blood vessels. Okay, but it dilates and relaxes the smooth muscle. So, and because of that, okay, because of the vasoconstriction, okay, that it causes in the blood vessels, that's why your heart rate becomes increased. So that's why somebody after, if they have asthma and we use an inhaler on them, or a patient uses a bronchodilator, right? Most of the time they're tachy after. And it's because of the increased heart rate, okay? So that's why it's always good to do your vitals, right? Because your vital signs is going to save you every time, right? So if I'm like, why is my patient's heart rate high? And then I look in the chart, oh, they just got a bronchodilator. then that's why I know it's not tachy because something's wrong with the heart, right? And their BP is not high because something's wrong with the heart. It's because they just received a bronchodilator. So this is for acute asthma, acute and chronic bronchitis, and COPD. We also give this for ARDS, which is acute respiratory distress syndrome. Okay. So that's something we do for that as well. Let's see. Tiotropium, this is an anticholinergic. Okay, it's probably one of the more popular ones. And this acts the same way, like a bronchodilator, right? Acts on the smooth muscle, okay, and reduces airway constriction. But again, remember I talked about some of these we can't give together, okay, because it has like an opposite effect. So uses mandatory respiratory symptoms of cough, difficulty breathing, mucus production. And this is usually used for COPD or that ARDS that I was talking about, acute respiratory distress syndrome.
Okay.
This is when we usually give our anticholinergics. Let me see. Oh yeah, we're almost done. Geez, that was quick.
Yeah.
Enzothiamines relax smooth muscle. Okay. Directly act on kidneys to produce an increase in urine and CNS effects. So, with this medication, do you think that this is something we should be giving with somebody with kidney disease?
Or which one?
For the xenithines.
Oh, is that for someone with kidney disease? You said.
Yes. Should we give this to somebody with kidney disease?
Probably not because it increases. Oh.
Exactly.
Yeah.
Okay.
Yeah.
Right, because it increases urine production. So if I have somebody who's on dialysis, right, this is probably not the bronchodilator I want to give them. Okay. So with this bronchodilator, we just have to be careful, right, with somebody in kidney failure, okay, and with somebody who has heart problems or heart failure, right or left, right, or congestive heart failure, right. Any type of heart failure, we want to be careful because it can cause, it can affect the cardiac muscle, okay, and it increases our rate of breathing. So this can be problematic, right, for these patients. So anybody with cardiac or kidney issues, right, we kind of, this is probably not the medication we're going to give. And if we are going to give it, there's probably a good reason. This is usually for like preemies. We give it to the preemies when they have apnea. And this is not like sleep apnea, right? Where for preemies, it's more of there's not enough stimulation going on in the brain to tell them to keep breathing. So they'll have moments where they have, pauses. So for preemies, we'll give this medication along with caffeine. A lot of people don't know caffeine. Yes, it is a drug. Okay. And we do give it. Okay. And we usually give it to stimulate the brain to keep the patient breathing, or to remind the brain to, hey, breathe, So this is using combined with that. Okay. It's also for acute pulmonary edema. Because again, it causes diuresis, right? So if I have somebody who has pulmonary edema for whatever reason, right, I want them to excrete more, right? I want them to get that fluid out. So this is kind of, a 2-for-1, right? Because it's going to open up the lungs, but then it's also going to help remove some of that fluid. Anti-inflammatory drugs. You guys cover more anti-inflammatory drugs in term 3 when you guys go get into cardiac.
Yeah, I think we did also for I forgot. Yeah, like in the beginning of the term, the
Hmm.
anti-inflammatories.
Right. And corticosteroids, that's also used for, it's also an anti-inflammatory drug, okay? So like we'll give it, like corticosteroids, for instance, we'll give it for like pericarditis, things like that. So anti-inflammatory, just like in the name, right? Anti-inflammatory. When we're talking about allergies, this is reduces that nasal congestion, right? Because when if you've ever had a sinus infection, it hurts. Why? Because all your sinuses are inflamed. They're inflamed, they're swollen, they hurt. And when things are inflamed, right, we have vasodilation going on again, right? Then we have more of that drainage. Okay. So this is going to help reduce nasal congestion. Okay. Treatment of allergic, mechanical, or chemical-induced local nasal inflammation or nasal polyps when usual treatment has failed to work. We obviously use anti-inflammatory drugs for different things. Right, like Excedrin, right? We went all over those drugs a little while ago, a couple weeks ago. For just swelling in the joints, right? Osteoarthritis, things like that. But for this is mainly for that nasal congestion, okay, or the sinuses. Adverse reactions, it could trigger an asthma attack, headache, lightheadedness, loss of the sense of smell, nasal irritation, dryness, nausea, nosebleeds, perforation of the nasal septum, altered sense, taste, and smell. Because this is going to be given in the nose. So if we're doing it for nasal congestion, it's not just like an oral medication, right? So that's why it said, it can cause nosebleeds, perforation of the nasal septum, things like that. We want to make sure our patients know how to properly use anything that's, we're being squirted into the nose. Because a lot of patients, they don't know as they squirt, they're supposed to breathe in, right? They'll squirt it and then breathe out. And that does nothing because you just breathe it out all the medication. Same thing with like an inhaler, right? For asthma or bronchodilator, right? We'd have them press, inhale at the same time, and hold for about 5 seconds, and then they breathe out, okay? Because otherwise, if they don't hold, they're just going to breathe out the medication. And they're not going to get the full effect. Rebound nasal congestion can occur with topical intranasal steroids. Steroids can also interact with other drugs, okay? Because again, it's a steroid, right? So, steroids can, interact with multiple drugs. So we just have to make sure that, we make sure the doctor has the full list of medications that the patient's taking. And that's also with any type of like herbs that they take as well. Because some patients take ginkgo and, all this other kind of stuff, right? But we have to make sure that we have that full list. Mucolists. Okay, so this is like, mucolytics are like,
Mucinex, whatever that's called.
Mucinex, exactly. This is your Mucinex, okay? So decrease the thickness of respiratory secretions, okay? Like we just said, that medication, you can find Mucinex, you can get it over the counter, right? Most of these meds you can get over the counter. It's an expectorant, okay? Commonly used with patients with COPD, whose mucus is thick and hard to expectorate. GI upset is common. Expectorants may increase bleeding tendencies in patients who are taking anticoagulants. Expectorants, so mucolytics, we also give, and you'll learn this in term 4 when you get into peds, but this is just for some general knowledge. We also give this for cystic fibrosis. So cystic fibrosis is a condition of what's happening is the cells are overproducing mucus, okay? And, what happens when you don't, if you've ever spit out mucus, and you let it sit somewhere, it gets hard, right?
Yeah.
And that's exactly what happens in your lungs, right? So mucus can become very thick. It can clog airways, okay? Same thing with like our babies, right? Sometimes, babies and kids, they don't know how to blow their nose.
Yeah.
So they have a lot of mucus, right? It can absolutely obstruct their airway. That's why, oh my gosh, what's that? I'll have to think about it. My niece had it. Not whooping cough. Oh my gosh. It's a condition kids get during flu season.
Uh-huh.
Oh God. Um, kids get in. I'm literally Googling it. What's it called? Let me see. It's a respiratory infection. RSV. There we go.
Okay.
I'm like, damn, what is it?
What is that?
But RSV. So RSV does the same thing because it's excess mucus, right? And it clogs the airway.
Yeah.
So we'll give like mucolytics for that to help thin the secretions.
Okay.
Helps treat productive cough, assists with thinking mucus. Okay, anti-intrusives. Okay, so these are our cough suppressants. Okay. Personally, I think most of the medications out there don't work.
Yeah, I have a hard time finding the one. I usually have to
Yeah, I haven't really found one that works. Either. But honey is a natural anti-intrusive.
I usually put that with my morning coffee.
So honey, and you know what? And honey is a really good for allergies as well.
Yeah.
So like they say to take if you're not allergic to honey, to take like a tablespoon of honey every day, and it actually is supposed to help not just boost your immune system, but it helps people who have a lot of problems with their allergies.
I didn't know that part.
But yeah, I'm sorry.
I said I didn't know that part.
Yeah. So I actually have a student in the term 2 daytime program who takes honey every day, and he said that he's like it's worked wonders because he I guess was really bad with allergies just all the time.
Yeah.
But yeah, so honey and so like what I tell like people like honey not lime, lemon, like hot water, lemon, and honey. A lot of honey can actually help with cough as well. But anti-intrusives work directly on our nervous system, right? Our central and peripheral, because it helps with depression. Okay. So some anti-intrusives we cannot give to children because of that depressive effect. Okay. It affects them too much, and it can actually cause them to stop breathing.
Oh, yeah.
Let's see. Soothes irritated areas in the throat, relief of overproductive or non-productive cough. Now, I would say the big thing when you have productive cough, right? The whole reason you have a productive cough is because your cilia is trying to, remember those finger-like projections?
Yeah.
They're trying to move the mucus up, right? And so that's why you keep coughing, because your body is trying to cause that response to cough up the mucus. Okay. And patients always complain, well, I cough more at night. Why do you think patients cough more at night?
I kind of want to say that it's I don't know, maybe it's just the air, maybe like is it colder or
no, it's because they're laying down.
oh yeah.
because you're laying down. So if you have a cough, this is,
Yeah, yeah, maybe put them in
you want to sit up. Yeah, you want to try to sit up slightly. Because that's why people are like, well, I cough more at night than I do during the day. Well, during the day, you're sitting up, you're walking around, right?
Yeah.
Where at night, you're laying flat.
Okay.
It's actually working against your body, right? So that's why you cough more. But, so...
Oh, that makes sense. Okay.
Right. So when we give antitrusives, we tell, we want to make sure we educate our patients that not only are we going to give them this medication, but they have to help it along, right? So sitting slightly upright, right, when they're sleeping, drinking lots and lots of water, especially if there's production. And with a non-productive cough, a lot of times the non-productive cough is because there's been irritation, right? So there's irritation in the lining. So drinking water helps, right? Honey, right? Anything soothing, right? But we want to help, right? So I tell my patients if they want to, and I do this myself. If when I'm sick, right, sit in the shower, right, and I just take deep breaths into the steam, right, to help open up my airway. Drinking a lot of water, and then do you know what the cupping technique is?
Cupping? Like with is that the Eastern medicine stuff where you put the fire?
Oh no! Here, watch. I'm gonna share my video with you, and I'll show you. Okay, so cupping. Okay, so they actually have. You can buy it. Literally looks like a circle with a little handle, and you can use it, right? Yeah. But cupping is you take your hand like this. Here, I'll show you. I'm gonna borrow one of my. I'm at my clinical site in South Dakota.
Oh wow!
I'm gonna grab one of my roommates for this. One second. I need a volunteer. I need to show my student what cupping is. One moment. Okay. Let's see. Okay. Hold on, my screen. I think I blurred my background. Let me see.
Yeah.
Okay, here we go. Okay. So for cupping, so turn around. So when we have somebody who has thickened mucus or any type of secretions, right, or we want to clear the airway, you're going to take your hand like this. You see how it looks like a C, and you're going to do this. You hear that sound? So you're going to do this all along the upper lobes, and especially if it's a lower respiratory infection, you really have to get into the lower lobes. And remember, in the back, okay, our lower lobes are here, okay? So it doesn't just stop here, right, like we do in the chest. The reason when we auscultate and we do other things is because here is our bowel, right? So we can't access the lower lobes through here. That's why we can only go from, right, maybe a little, from the diaphragm up.
Okay.
Where the back, we have a better chance at loosening those secretions. So that's where you're going to do cupping in the back. Okay? And really get into those lower lobes. Okay? You can even do it in the sides as well, but it's mainly in the back for lower respiratory and in the front in the upper portion for upper respiratory infection. Okay? Okay, thank you. So that's what we're going to do, especially for those, like I said, those lower respiratory infections, and especially with like our kiddos, right? Because they don't know to, right? They don't know how to like cough it out. So steam works really good along with your anti-intrusives, right? So steam, cupping, right, and that water. We're really pushing water because we want to thin the mucus, make it easy for you to cough out. Because have you ever been really sick where you have a lot of mucus and then and you've just been coughing and coughing and coughing, right? And it's like really annoying. And then all of a sudden you cough out like this huge hoggy. and then you're like, and then you just stop coughing.
Yeah, it just feels better. Yeah.
Right, and that's because that cilia, right, that those finger-like projections is literally like a dung beetle. How a dung beetle rolls feces up. That's exactly what the cilia is doing, but it's rolling it up. Okay, and that's why when you lay down, you cough more because now the cilia has to work against the gravity.
Yeah.
It's going to take longer. Okay. So those are our anti-intrusives: adverse reaction, drowsiness, dry mouth, nausea, postural hypotension. That's why I said that we are very, very careful with our little ones when we give these type of medications, because a lot of that drowsiness, right, that sedative effect, because it's acting on our central and peripheral nervous systems, can be bad for them. Okay. That's why it's very important that we follow, on the medication cups. There's a medication that actually, it's on the market for kids, but you shouldn't give it. Let me see, cough medicine for kids. I'm going to.
Habitat or something?
Robitussin.
Robitussin. Okay.
Robitussin. There's been studies that it's not good for kids. So, like, I'll give my daughter, I've given her Mucinex for kids. Zarbee's, I like Zarbee's because it has honey in it. And it's more of a natural effect. But yeah, so that's kind of it for your slideshow. It was very quick.
Yeah, like I said, it was really short.
And you have your final coming up, you said?
No, we have a musculoskeletal exam, and then we're going to have a quiz for this. But after that quiz, will already be the final, and that'll be like the last of pharmacology for term 2.
Okay, when do you take that? Is it before or after tutoring?
Yeah, that should be 2 weeks from now. So.
Oh, okay. So then we have some time.
Yeah.
Okay. Then next tutoring session, since you have your final coming up, we'll just do questions like NGN questions, multiple choice, right? Psychology apply. We'll just do questions on Pharm.
Yeah, that'll work. Yeah.
If you're okay with that, that way we can see. You're pretty good, Justin. I don't, like I said, I don't worry about you at all. But maybe if there's something, right, that you maybe want some clarification on.
Yeah.
Then, just kind of fine tuning some stuff, maybe tweaking a little bit, but yeah, we can do that the next time around.
For sure. Yeah, my thing is just really trying to figure out how it all links together, because it's mostly memorization, so it's like this with with med search, I can kind of think my way into the question a lot easier than I would with like pharmacology, where it's like if you don't know the adverse reaction, you don't know the adverse reaction. You know what I mean?
Right. So pharmacology is a hard subject, and it's one of those subjects that I say comes with time.
Yeah.
It definitely, I didn't really, because I struggled with pharmacology really, really bad in school, in LVN school. And I will say, when I became a floor nurse and I was administering these meds and all this stuff, then it starts clicking, right? So, there's having a base, we just need you to have a basic understanding, right? Of what's going on. And you guys will have more pharmacology with certain things, like in third term you do renal and cardiac meds.
Yeah, I think we have another set.
You'll do endocrine medications, things like that. So they'll kind of fine tune. Where right now you're kind of getting a broad generalization of everything. But it will be, as you go on in your terms, things should be a little bit more clear. I won't say that you're gonna know every med out there, right? But no nurse does. Nobody knows every single medication side effect. There's too many.
There's new ones every
and
year.
they're right. And they're coming up with new things every day. And then it also depends, right? If the patient, most patients have multiple conditions, so
Of course.
but it just comes with time, you know. It just comes with time. But you should be fine. Like I said, I don't worry about you at all. When I ask you questions, right? You tend to find the rationale, or you know, and sometimes if you're wrong, you're close.
Yeah.
Like you're in the ballpark, right? We're not like shooting in outer space here.
Exactly.
So, but you'll be fine. Just kind of review your PowerPoints that you have, and just, you know, what I would suggest is writing down, say, like antitrusives. One sentence. Give me one quick sentence on what it does, on what these meds do. Right? Same thing with bronchodilator. What does bronchodilator do? Dilate the bronchial, right? Open up the air. And then give me 3 or 4 adverse effects and 3 or 4 side effects.
Yeah.
And then a very brief patient teaching, right? Maybe 1 to 2 sentences on what you would tell your patient. And then that's what you should use to study.
Yeah. That's how I study my notes.
Oh, good. And then your ATI book. In your those little icons.
Yeah. Yeah.
Did I show you guys those little
I've been
icons?
highlighting them lately.
Yeah, so those little icons, pay attention to those, because those are what's going to be on the ATI driven exams. So, you know, just kind of look at those over a little bit, and add them to your notes, right, if they're not already. But that should, you know, really kind of help too. But yeah, like I said, Pharm's just, it's one of those that's, you know, just comes with the time. But as you go over more and more diseases, right, you'll see the same category of meds every single time.
Yeah.
And it'll become a lot more clear. But do you have any other questions? Do you want to go over anything?
Well, I mean, it's a little off topic, but I'm just kind of thinking ahead. Does the school offer tutoring for all the other terms as well? Or just
Yes.
for term 2? Okay.
I do tutoring for all 8 cohorts,
Oh, nice. Oh,
for all 8 terms. So when you go to term 3, it'll be me.
oh, awesome. Awesome. All right.
Yeah.
Look forward to it.
Yeah. So,
Okay.
but
Well,
all right, then. Well, you have a good night. If there's no other questions, you can always, you know, email me, text me, reach out any way you need me to. I did email you earlier, because I had said, like, oh, if you wanted to meet now for tutoring.
oh, sorry. I was.
No, don't worry about it. Don't worry about it. It's just because my term 1's never come to tutoring.
Oh, really? Oh.
So the slot is open for 2 hours. So I'm like, well, I might as well just, you wanted extra tutoring, you know?
Yeah.
But yeah, so, you know, if you need me for anything, I'll be back on campus on Monday.
Okay.
But even if you need me while I'm here in South Dakota, you know,
Yeah.
feel
I'll
free
email.
to.
Yeah, I'll reach out for sure. Okay.
Okay.
All right. Thank you so much.
You're welcome. You have a good night.
Okay. Same to you.
All right. Bye.